Hi everyone, welcome to the head-to-toe physical exam video. I'm Frank Tenuto, I'm one of the hospitalists working here at Rush.
I'm Jordan Sharping, I'm one of the internal medicine residents.
So the purpose of this video is to go through the whole physical exam checklist here. We're going to go from top to bottom, from number 1 to whatever 145 it is on there. The purpose of this video will be mostly to go through how to perform the exam maneuvers and not so much why we're doing them. That's more so for the clinician perspective videos. But this one will be more so just how to do it, the techniques behind it, and maybe a couple tips here or there. So Jordan's got the list pulled up in front of him on his iPad. He's literally going to read through just as we're going through. So if you guys want to follow along with your checklist at home, that'd be great. If not, if you just want to sit back and watch, that's great as well. But we'll start with pretty much number 1, and we'll go through the sections here, and then hopefully this will help make the physical exam a little bit easier for you guys going forward. All right.
Okay, so the first thing you obviously want to do is introduce yourself to the patient, your role on the team, and then state what you're going to be doing, the exam you're going to be performing, and then of course wash your hands before starting the exam, and then we can get into it.
Sounds good.
Let's start with vital signs. Place the blood pressure cuff above the antecubital fossa on the elbow on the skin.
All right, so we've got the cuff on the wall over here. As Jordan said, for number 1 and number 2, always important, just introduce yourself, what your role is on the team. A lot of the patients here, they see medical students, interns, residents, attending physicians, consultants. So just always state your role. I think they appreciate that as well. And then obviously wash your hands, whether it's with the sanitizer or over with the sink. I did that before we started, so I'm good to go. Now we're going to start by taking the blood pressure. Always make sure that it's a good cuff size too. This is the adult size, so this typically works for most people, but sometimes if people are a little bit bigger or a little bit smaller, you may need to adjust accordingly. Otherwise you can get a falsely high or low reading. So we've got the cuff wrapped around there. Ideally we want the arm at heart level. Sometimes it's not the end of the world if you do take it with the arm by the side. It's a little bit more comfortable for people. But in theory we're supposed to take it with the arm at heart level. So we'll go ahead and do that, and then I think if we want to keep going along through there.
So you will do this actually in both arms while supporting the arm at the heart level, as Dr. Tenuto said. You'll place the diaphragm of the stethoscope over the brachial artery, and then you'll inflate the cuff and slowly deflate the cuff, generally between 5 and 15 seconds without allowing the dial to drop too rapidly.
Okay, so I'm on the brachial artery here. Usually try to get a little bit of your diaphragm underneath the cuff, but it's not a huge deal if you don't, and you try your best to help support the arm as well. I positioned the BP monitor back there already so I can get a good view of it while I'm pumping up here, but I'm going to start inflating, and I go nice and slow until I can start hearing some of the heart sounds. And I'm hearing them now, so I'm going to go ahead and just keep going a little bit higher then until I hear the last sound. Jordan's a pretty healthy guy, so I don't anticipate we're going to go too high with your pressure, but we'll go ahead and start dropping it down and see what your blood pressure is running here. So I heard the first sound there at 118, and now I'm listening for the last sound, which will be his diastolic. About 72 is where I heard the last sound, and then you can go ahead and deflate the cuff. So 118 over 72, pretty perfect blood pressure. Ideally we'll take that in both arms, but for the purposes of this video we'll just do it in the right arm. But make sure it's always important to take it in both arms. Put that back up there. Alright, what do we got next, Jordan?
Okay, so let's palpate the radial pulse for at least 30 seconds. And then while we're doing that, we're going to determine the respiratory rate while keeping the hand on the wrist for 30 seconds. And you don't want to inform the patient that you're assessing the respiratory rate during this actual exam.
So I felt his pulse for about 15 seconds here. He was actually right at 20, so 15 times 4. We've got 80 for his heart rate, and actually what I'm doing now is looking at his chest to watch his respirations. It's a good idea to not let patients know that you're counting their respirations, because if you tell someone to breathe normally, they start breathing abnormally. So just let them know you're feeling their pulse, and as you're doing so, you can watch their respirations. Jordan had about 3 or 4 there in about 15 seconds as well, so he's anywhere from like 12 to 16 or so. So normal blood pressure, normal heart rate, normal respirations. That should be it for most of the vital sign stuff. All right, so we're on to the head and neck section. Jordan will go ahead and read off the next number there.
Okay, so this is number 10 in the head and neck section. Observe and then palpate the scalp and ask the patient to bend their head slightly forward, inspect the skin by parting the hair with your fingertips, and then assess for scaliness, lumps, or other lesions.
Okay, so while I'm standing here, I'll go ahead and I'll look at the back of Jordan's scalp and any of the skin over here, as he said, looking for any sort of lesions, asymmetry, etc. And then same thing, I'm not going to part his hair or anything because it's very nicely combed today, but you just want to make sure that you're looking for anything that jumps out abnormally on the exam.
So then you verbalize the inspection of the face and skin on noting, facial symmetry, contours, and lesions. That's number 11.
Okay.
Let's see, and then number 12, so palpate the frontal sinuses bilaterally and ask if the patient feels pain.
Okay, so I'm going to go ahead and push on Jordan's frontal sinuses here. Any pain when I'm pushing?
Nope.
Okay, sometimes it's nice to give a little bit of support in the back so you're not just pushing his head backwards, so you go ahead and push on the frontal and no pain there.
Okay. Then you palpate the maxillary sinuses bilaterally and ask if the patient feels pain.
Similar here, so I'm going to push on the maxillary sinuses in this area. Any pain or discomfort?
No.
Okay, just be careful if someone does have glasses on, just so you're not irritating their glasses or pushing them or anything.
So then you want to inspect the internal nose and the bilateral, that would be the bilateral nasal terminates with the otoscope, and ask the patient to look up, place the pad of the finger on the tip of the nose, and then lift as gently to insert the speculum and do that.
Okay, so typically it's good to have the patient just look up and either focus on something in the ceiling, one of the panels or one of the lights or something. I've got the otoscope ready back here. Always make sure you guys put a cap on it as well, just for patient comfort and for sanitation purposes. So Jordan will look up. If you want to have them push up on their nose, you can. Typically you're able to get a pretty good view without having them do that. So you go ahead and you look at both sides. And I can see his turbinates right there. I'm going to sneak over on this side. Take a look on the other side. And same thing, I got a good view of his turbinates there as well. So that's the main thing you're looking for, the little bony cartilage that's in the middle there. And then always make sure you change the cap on that afterwards. So I'll hang that back up. We'll use that again later. We'll get rid of that cap. I'll come back to this side and we'll keep going through the exam here.
Okay, next is number 15. You inspect and palpate external ears bilaterally. Examine the front of the ear and then pull the pinna forward to look behind the ear.
So I'm going to go ahead and just feel the ears, visualize, see if there's any sort of abnormalities, and then you go ahead and pull the ears forward just to see if there's anything that maybe jumps out as far as abnormal on the exam. So just a pretty easy way to visualize and inspect the ears.
So the next one is to examine the inner ears bilaterally. So to do this, you'll pull up on the pinna to straighten the ear canal, and then you'll place the tip of the otoscope speculum into the entrance of the ear canal, and be careful not to advance it at this point, and then lean in to look through the otoscope and visualize the tympanic membrane, and obviously on the other ear as well.
Okay, so I got a new cap that I'm going to use here. I'm going to put this on, and then as Jordan mentioned, I'm going to pull up on the ear a little bit and just rest the scope on the edge of the ear, and once I get a good visualization, I'm going to go ahead and look a little bit further, and you're going to look all the way until you can see the tympanic membrane. Typically you don't have to push in very far to see it. I can see it actually right from here without even going too far. And I'm going to come over to the other side, take a look at the left ear here. You can use whatever hand's more comfortable for you, but pull up on the ear a little bit, rest it, and then take a look in. And I got a pretty good view of the membrane there as well. Sometimes you can see some fluid, sometimes you can see some erythema in the ear canal. So those are a couple things you're keeping an eye out for. Once again, you take your cap off so we can toss those. And I'll come back to this side again. All right, moving on.
Okay, so next we're going to inspect the mouth. That includes, of course, the lips, the buccal mucosa, the gingiva, tongue, undersides of the tongue, and teeth. And then you use a tongue blade to pull the patient's cheeks out, inspect the teeth, gums, and lips, and then ask the patient to lift their tongue and inspect the underside. And then obviously you want to use a light.
So first thing, you're just going to take a look. Sorry, I'm going to grab the light one more time here. You're going to take a look at the external mouth to see if there's anything that's abnormal. Then you'll ask the patient to open up. And I just take a quick glance before I have them do anything else. You want to make sure you're looking at the cheeks, the top, and then if you can lift your tongue up, please. Very good, and tongue down, and say ah.
Ah.
Very good, and you can go ahead and relax. If you want to use the tongue blade to have them push their cheeks out a little bit, you can as well. Personally, I don't think it's very necessary, especially if you can get a good view of the mouth just by itself. So in this case, we're completely fine doing that.
Okay, and then you verbalize the inspection of the tonsils and posterior pharynx with a light source. And then you want to go to the next part. You would palpate the preauricular nose bilaterally. That would be in front of the ears, directly anterior to each tragus.
Okay, so we're looking for any sort of lumps or bumps here, any sort of lymph nodes, as Jordan mentioned, in front of the ears. I don't feel anything over there. And then same thing, no lymph nodes or anything that I can feel in front of the ears.
And then you would, this is number 20 by the way, palpate the posterior auricular nose bilaterally, that is behind the ears over the mastoid processes.
Okay, so feeling behind the ears over here. This is actually where you're a little bit more likely to find some nodes, especially for people who may be sick, especially in the winter season, but I don't feel anything for Jordan behind his ears. Once again, we're looking and we're feeling for any sort of lumps or bumps or abnormalities, nothing that I see on the exam here.
Okay, next you would like to palpate the anterior cervical node bilaterally. To do that, you palpate anterior to and over the sternocleidomastoid muscle throughout its whole length.
Okay, so typically your sternocleidomastoid muscle runs right along this path right here. So we're feeling for any sort of lumps or bumps. And you want to use just the tips of your fingertips just so you get a good but light palpation of what you're feeling for. The lymph nodes can be subtle sometimes, so a little tough to feel, but usually just some light palpation should be enough to find them.
Okay, next, palpate the posterior cervical nodes bilaterally. That is, palpate posterior to and under the sternocleidomastoid muscle throughout its whole length.
Okay, so now we're just going on the lateral and the posterior side of the neck, just behind the muscle. And then I'll feel on this side as well. Sorry if my view is obstructed, but we're doing the same thing, just kind of feeling lightly with your fingertips. Nothing that I feel back there.
Okay. Now palpate the submandibular nodes bilaterally. To do that, you'll palpate between the angle of the jaw and under the chin, which would be the submental nodes.
Okay. I did that a little bit as I was palpating the anterior nose, but this is where you get a better feel actually under the chin here. Sometimes if the parotid gland is a little swollen, you can feel that too, but you're really trying to feel under the chin to see if you can feel anything. Nothing that I felt on exam.
Okay, now you want to palpate the supraclavicular lymph nodes bilaterally, and that would be above the collarbone.
Okay, so supra means above, and clavicle obviously is our collarbone, so we're feeling in this general area. Pretty common spot to find lymph nodes as well, but I don't feel anything here on Jordan. You can feel a little bit in the chest region too, but no, nothing that I feel there.
Okay, and then ask the patient to swallow while you observe the thyroid gland.
So this one's strictly just observation, so I'm going to ask Jordan just to look forward, and if you can just swallow when you get a chance, and I'm just going to watch his thyroid. Perfect, and it's a little tough to visualize, but you can see the thyroid is right in this area, and it moved appropriately as he swallowed, so that's the main thing we're looking for there.
Okay, and the last part in this section, number 26, palpate the thyroid gland. To do this, you'll place the fingers of both hands immediately below the cricoid cartilage, either anterior or posterior approach. You'll slide the hands laterally until fingertips are just off the trachea. And with one hand, press soft tissues, the soft tissue, i.e. the thyroid, medially. Palpate the displaced thyroid lobe with your opposite hand. Reverse for the opposite lobe exam. And then return the thyroid to its resting position and have the patient swallow while palpating the thyroid.
So that's a lot. It's a complicated exam maneuver. It's really tough to feel thyroids in the individual lobes, actually. You can do this from either approach, however you feel comfortable. Some people prefer to go from the front because they can get a little bit of a better feel for the thyroid. I personally prefer to go from the back because I feel like I can personally get a better grip from it. So as Jordan mentioned, you're trying to feel the cricoid cartilage, which is pretty much like a lateral band of tissue that goes across the thyroid. It's a little tough to palpate sometimes, but I can feel his here a little bit. So what I'm going to do is go on the sides of that then, making sure not to push on his trachea, but more so on the two lobes of his thyroid, and I can feel them as I'm pushing a little bit. You just want to make sure that you can push them and that they're mobile, and then feel if there's any lumps or bumps or any nodules or anything. And then when I'm done palpating the thyroid, I'll always ask the patient to swallow just to make sure that the thyroid moves appropriately. So Jordan, when you get a chance, if you can please swallow. And that's perfect. As he was swallowing, I can feel both lobes moving appropriately. Neither was stationary, both moved as they should. So I believe that's it for that portion of the exam. So go ahead, we'll move on to the pulmonary section here. I'm going to hang up this light actually as we do that, and then we'll jump right into the next section here.
Okay. So this is the pulmonary exam, this is number 27. So the first part, you will verbalize inspection of the posterior thorax for scars and or asymmetry, and you can ask the patient to untie the gown to expose the entire back.
Okay,
So I'll turn for
sounds good. So Jordan will turn this way so we can get a better view of his back. Typically I would do this just standing on the patient's right once again, because obviously we're going to be behind them, but for purposes of this video, Jordan will swing his legs over that way and we'll look at his back. And then if it's okay with you, I'll go ahead and untie this just so we can get a better view, so we can walk through what we're doing here. Okay, so the first section was just for visualizing anything in the posterior thorax. I'm looking at both sides of Jordan's back and I don't see anything abnormal, anything that jumps out. So we'll go ahead and move on to the next step.
Okay, palpate tactile fremitus. So to do this, you'll place the ulnar surface of both hands on the upper, middle, and lower lung fields and ask the patient to say 99 and compare left to right at each level.
Okay, so this one can be a little confusing. So they're talking about the ulnar portion of your hand, so that's this side by your pinky. And what you're doing is you're going to go upper, middle, and lower on both sides. And personally, I like to use just one hand to do it, and I like to alternate side to side so you can compare left upper versus right upper, and then working your way across. So, and you ask the patient to say 99, and you're actually going to feel the vibration a little bit along your hand. So Jordan, if you could please say 99.
99.
Again.
99.
Again.
99.
Again.
99.
Again.
99.
And one more time.
99.
And as he's doing that, you can feel a little bit of the vibrations and the resonance there on the ulnar surface. It felt and sounded the same on both sides, so nothing that I'm too worried about back there. And then the next step.
Okay, percuss the posterior lung fields bilaterally and symmetrically over the upper, middle, and lower lung fields, comparing each side left and right.
Okay, so this one's also a little bit tricky. Percussion's always a little tough to do, but what I like to do is similar to the pattern I did for the 99. I start in the left upper and then I'll go side to side as I work my way down. I tend to use my middle finger for percussion, and I try to do the last joint over here, and then I'll actually use the other middle finger on my other hand to do the percussion. And you're not, it's a little tricky to get the hang of it, but you're just trying to pretty much hit your nail with the tip of your finger and in order to make a sound. Always, honestly, one thing, make sure your nails are a little bit shorter too, because that can actually hurt your skin a little bit. And you're trying to find the grooves in between the ribs, because if you hit the ribs, it's going to be a pretty, you're going to hear more dullness, but if you're actually in the space between the ribs, it should be a little bit more tympanic. So. Once again, a little tricky to do, but there we go. Back and forth, both sides comparing left to right. Sounds pretty normal on both sides. All right.
Okay, number 30, auscultate both the posterior lung fields bilaterally and symmetrically over the upper, middle, and lower lung fields, comparing each side.
Okay. So this is where we actually go ahead and take a listen here. So personally, I just like to start from the bottom and work my way up, but always alternating so you can compare left versus right. So I usually start in the left lower and ask the patient to take a deep breath. And now right middle, left upper, right upper. So it's always important to make sure that you guys get each of the quadrants, just because there can be abnormalities in any area. It sounds nice and equal bilaterally for Jordan, so we'll go ahead and move on to the next step here.
Okay, so number 31, you want to verbalize inspection of the anterior chest now for scars or asymmetry. Ask the patient to lower the gown to below the collarbone and expose the upper chest.
Okay. So I'm going to go ahead and tie the gown in the back here because for right now we're done looking at the back. And then I'll have Jordan swing his feet around a little bit back to the front here. And we won't have to drop the gown down completely, but for the most part we're just looking at the anterior chest, mostly the upper fields here just because you can hear that a little bit, and I don't see anything abnormal there, so we'll move on to the next step.
Okay, next, percuss the anterior lung fields in one area on the upper chest bilaterally and symmetrically.
Okay, so really the only area you can do is the upper lung, so we'll do one more percussion over here. And typically you shouldn't really hear anything too dull there. It should be a little bit more tympanic because there shouldn't be any sort of consolidation or opacity or anything there.
Okay, and the last step in this part of the exam, auscultate the anterior lung fields in one area in the upper chest bilaterally and symmetrically.
Okay. And this is important too because you can definitely hear some anterior lung sounds, especially based on body habitus or patient positioning. And sometimes you can even hear wheezing from the front. So always important to have the patient take deep breaths and listen to both the right upper and the left upper from the front side as well. So I think that's it for the pulmonary section. We're just moving along here at the cardiovascular section now.
Okay, so for the cardiovascular section, you want the patient to lie down, and then you want to, when the patient is supine, pull the leg rest and cover the legs with a drape. And then from there, so this is number 34, stand to the right of the patient for the entire exam, and then we'll go into the JVD.
Okay, sounds good. So I'll have you go ahead and I'm going to prop the bed up a little bit,
Okay.
just because the first portion of the exam is to do JVD. So that one you want them at about 30 to 45 degrees. This bed in particular doesn't have the marker on it, but a lot of the beds in the hospital have the little degree marker down here on the side, and you can actually, it gives you the digital number, so it's easy to help line up. But pretty much you're trying to split the difference between 0 degrees, 90 degrees. We're at about 45 there, so I'll ask Jordan to lay back a little bit here and make sure that you kick out the leg representation because that could be a little uncomfortable. If they'd like as well, you can also cover them with a drape or a blanket, but in this case, I think Jordan's okay, but if you would like anything to help cover, let me know. All right. So then, if you want to go ahead and read the JVD portion, which is always a little bit tricky, but we'll go ahead and we'll talk through it.
Yeah, so you're going to assess the jugular venous pulsations. To do that, you place the head of examination table 30 to 45 degrees, like Dr. Tenuto said. Ask patients to turn their head to the left, and while lying down on the incline, you shine a light on the right neck and just superior to the collarbone to visualize these jugular venous pulsations.
Okay, so I ask the patient just to focus on something on the wall. If they need a pillow, you can give them one, but honestly, it's a little bit more accurate without a pillow. So I'll ask Jordan just to look at either the cords on the wall or the little banister over there on the edge. And first thing, I'm just looking at the veins over here on the side of his neck. Don't be confused by what you can see as sometimes the external jugular or the sternocleidomastoid over here, but we're actually looking more so in this area. And as of right now, I don't see anything that's too exciting here. What you can try to do though is occlude it a little bit. And as you push on it, sometimes you'll see a little bit of pulsation there. Jordan, if you get a chance, if you can just try to bear down a little bit, sometimes that can actually help it. So actually you can see him coming up nice right over there. So you can go ahead and relax. So you can see he had some good jugular venous distension when he Valsalva or bared down over there. You can also cheat a little bit and push under their rib on their liver. It's called the hepatojugular reflex, and that can help push up some of the regurgitation into the vein as well. That could be a little uncomfortable for patients, so just be careful when you're doing that. But typically, if someone has a lot of fluid on them, you'll be able to see it just by visualizing. You can also use a light source. It's a little bit tricky to see, and depending on how the exam room is lit, you don't always get a good view of it. But in this case, I actually don't see any pulsations from any of the angles that I'm looking at, so I don't think I'd be able to pick up anything with a light source, but it doesn't hurt to look sometimes. We'll pass that though, just for the sake of time here. Okay, so that's it for JVD. Moving on, we'll go ahead and see what the next step is here.
Okay, and now you want to go and lower the exam table so the patient's supine, and then start with, this is number 37 by the way, auscultating the carotid arteries bilaterally. Doing this carefully doing this before palpation.
Okay, so I'm going to go ahead and drop Jordan down here. Once again, always make sure that you offer your patient a pillow just for comfort purposes. And then what we're doing, as Jordan said, number 37, we're going to go ahead and auscultate the carotid arteries. So it's always a little bit better to have the patient hold their breath while they're doing so, but just be sure that they take a breath in between each side, because it can be a little tricky to hold your breath for that long. So if you're okay just holding your breath for a couple seconds here, I'm going to listen to your right internal carotid. And I'm going to listen for a few seconds and then have the patient relax and breathe out. Let them catch their breath for a second. And then ask you to hold your breath again while I listen to the left side over here. Okay, and go ahead and relax and breathe. And that should be it for auscultating the carotid arteries. The next step here.
Okay, and now you want to palpate each carotid artery separately.
Okay. So I'm going to start on the right side over here, and I'm just going to push. Not too hard though, because it can be a little uncomfortable by the neck. And you're going to palpate for a few seconds. And then relax. Give them a second or so, and then go ahead and switch over to the other side. And you're going to feel for the carotid on this side. And palpate for a couple seconds. Just word to the wise, don't palpate both sides at once, because you can decrease the blood flow going up to the brain, and they may pass out here on the table. So not ideal, so make sure you do it at once, give them a second or two to catch their breath, and then go to the other side. Okay?
Okay, so now you want to have the patient lower the gown to below the xiphoid process and visualize and verbalize the inspection for chest movements.
Okay. So as we did for the posterior thorax, we're going looking at the anterior chest. We can leave Jordan covered here just for sake of modesty, but we're pretty much just looking at anything on the anterior chest that may be abnormal. Sometimes you can even see like a heave or some pulsations by the heart, but just looking, I don't see anything that is grossly abnormal. So moving on.
Okay, this is number 40. Place the finger pads over the aortic region. This would be the second to third right intercostal interspace to palpate for any thrills or pulsations.
Okay. So that's typically in this area, the aortic region. As Jordan mentioned, it's usually the first to second, second to third right intercostal space, and you're just palpating. And I'm going to go ahead and just move along for the other steps here. So you're going to palpate in the pulmonic area as well, and then the tricuspid, which is about the fourth or fifth intercostal space. For this one, you can actually use the palm, the tips of your fingers, or the ulnar surface of your palm, because that one could be a little tougher to feel. And then same thing for the mitral area, which is fourth or fifth space, about mid-clavicular line, sometimes a little bit further over laterally. And same thing, you can use your fingertips or the ulnar palm area. Okay, if you want to go ahead and read through the next one, I think there was a couple steps there because we just did them
Right,
over there.
yeah, so you did number 41 as well. That was over the pulmonic area, and then you placed the ulnar side of the palm over the tricuspid region. That was number 42. And now number 43 would be palpate the point of maximum impulse by placing the finger pads over the mitral area, which would be the apical area, fifth intercostal space.
Okay. So yeah, that one, you may hear that as PMI sometimes, or point of maximal impulse. If you don't feel anything in the mitral area, you can go a little bit further laterally towards the apical area, and you should be able to feel where the heart is pretty much pulsating or beating at its strongest. That's called the PMI, the point of maximal impulse. That may be shifted in some patients depending on body habitus, size, or if they have hypertrophy of their heart. Okay?
All right. And now, number 44, you want to auscultate the heart sounds in all four regions, the aortic, pulmonic, tricuspid, and mitral, using the diaphragm of the stethoscope.
Okay. So before I do that, I'm actually going to grab my other stethoscope over here just to show you guys a little comparison. I'll come back over here on Jordan's right. So I actually have, this is the Littman 3 stethoscope. So this one doesn't have a formal bell portion on it, but what you do is when you're listening, if you just put gentle pressure, that's the bell, and if you push down a little bit firmer, that's the diaphragm. That's for this newer Littman 3 series. I think a lot of people probably still have the Littman 2, which is a little bit more common. This is the one that I first had as well. So this is a little bit more formal. This is the bell portion, and then That's the diaphragm portion of it. So just for purposes of this exam, I just wanted to show you guys what both stethoscopes look like. Obviously, it doesn't matter which one you use, which one you have. They both serve the same purpose. But I'm going to use the stethoscope that I am more comfortable with, which is the newer one. So first of all, we're going to do the diaphragm portion in the 4 areas, and that's pushing a little bit harder with the newer one. So right now I'm in the aortic region, listening, pulmonic, tricuspid, and mitral. And it's always good to listen a little bit further over too to see if you can hear anything in the apical area. And then I'll work my way back through and use the bell portion so I won't push as hard this time. That was atrial, this is pulmonic, tricuspid, and mitral. Okay, so that was auscultation with the diaphragm and the bell portion. And I think there's one more portion there.
Yep, last portion, 46. So have the patient turn on their left side while lying down and auscultate the cardiac apex, i.e. the mitral area, using the bell of the stethoscope.
Okay, this one's a little bit tricky to do. To be fair, we don't do this all the time in clinical practice, but what you're going to ask to do is ask the patient to rotate onto your left side. That's called the left lateral decubitus position. We'll make sure you stay decent back here. And then what you can do is, if you're on the patient's right side, you can go ahead and listen, just reaching over a little bit. Sometimes based on body habitus or patient preference, you may have to go around to the other side to listen. But you're listening with the bell portion and you're trying to reach all the way down into that mitral or apical area. So I'm going to reach over and take a listen. And this is the bell portion, so I'm not pushing too hard here. And then that should be it. And then you can roll back onto your back here, please.
All right, so now on to the next part. This is number 47. Before you do this, ask the patient to restore the gown so the chest is covered. Remove the drape to expose the lower legs only if the drape was on. And then, so now it's the part for pitting edema. So you're going to do that, assessing pitting edema bilaterally, pressing the thumb or finger on the distal third of the tibia for 3 to 5 seconds over bone, and then inspecting the area to ensure there are no indentations after you release.
Okay, so Jordan's legs are exposed here. You can honestly do this if they're lying down or if they're off the edge of the bed. It's a little bit more comfortable sometimes if they're lying down, especially if you're going to be pushing on their legs. For one thing, they've got the bed underneath them to serve as a little bit of support there. And then as he mentioned, you're going to push on the bone. You can use the tips of your fingers or you can use your thumb and your pointer finger combination. And you're just going to work your way either up or down. And you're going to push and just see if it indents anywhere along the legs. Jordan, I can safely say, does not have any pitting edema, but make sure that you work your way up all the way from the ankle and honestly up to the thigh. You can sometimes see some edema in people's thighs and their sacral area depending on how they've been lying, but most importantly you want to check the lower legs, and I don't see anything that's concerning. All right, moving on to the pulse section here.
Okay, so this is number 48. Palpate the popliteal pulses bilaterally, and this will be behind the knees.
Okay, so I like to palpate them at the same time just so you can compare left to right. And I'm going to go ahead and reach just behind the knees a little bit here. And you got to get a little bit of pressure in order to feel them. And I'm pretty much using my 2 fingers just to push a little bit. And I can feel them. They're nice and symmetric on both sides.
Okay, and then you palpate the posterior tibial pulses at the ankle behind the medial malleolus bilaterally.
Okay, so I'm going to feel for these posterior tibialis pulses, as Jordan said, behind the medial malleolus, which is the bony prominence. Sometimes you have to move a little bit more superior or even inferior on some patients because the vasculature could be a little bit different. So actually I can feel his a little bit better as I move superior here. They feel nice and equal bilaterally. And then the next portion, Jordan?
And then you palpate the dorsalis pedis pulses at the top of the foot, lateral to big toe tendon bilaterally.
Okay, so this one, as he mentioned, is just a little bit lateral to that first tendon on the big toe. And usually if you find that groove there, you can feel the pulse. It's usually pretty easy to find. It could be a little bit tougher if someone has some bigger feet or if they have bigger body habitus or some vascular disease. But in this case, I can feel both pulses and they feel symmetrical all the way down on both sides. Okay.
All right, next portion of the exam is the abdominal exam. You want to do this when the patient is lying down. Now this is number 51, so stand to the right of the patient for the entire exam,
Okay.
and then ask the patient to raise the gown to expose the entire abdomen, draping the pelvic area and lower extremities with the sheet.
Okay. Are you okay pulling the gown up for a little bit? And we can go ahead and just keep you covered by your lower extremities just so we can walk through what we're doing here. So it's obviously more accurate if you do it based on the skin. If someone is very uncomfortable doing it, that's not a problem. You can do it over their shirt or over the gown, but it's just a little bit more accurate and you get a better, more true physical exam when you go ahead and look at the actual abdomen. So just make sure the patient's comfortable, make sure their legs are extended, you can keep them covered up, and then just for sake of decency, you want to make sure that you keep them covered up as much as possible and just expose the areas that you're going to be looking at. Okay?
Okay, so you verbalize inspection of the abdomen for color, contour, symmetry, and movement.
Okay, so I'm looking at the abdomen and it looks symmetrical on both sides. I can see his chest pretty much rising appropriately and I don't see anything out of the ordinary. So verbalize the inspection of the abdomen.
Next, you will auscultate the abdomen prior to percussing or palpating in all 4 quadrants, right, upper, lower, and left, upper, lower.
Okay, so this is important to make sure you guys auscultate before doing anything else because it can throw off some of their bowel sounds. So I'm going to auscultate in the right upper, right lower, left upper, and left lower. And you want to listen for a couple seconds in each area.
Okay, next, percuss the abdomen in all 4 quadrants.
Okay, so this one could be a little tricky as well as we did for the posterior thorax, but we're going to go ahead and go through the same areas we just did. And I'm going to use the middle finger on my left hand, and I'm going to percuss with the middle finger on my right hand as I did on the back as well. And it should sound, it's a little combination of dull and tympanic there, but it should be pretty much the same throughout. If you notice something's a little bit different, that could be concerning for some air that could be in the stomach or a possible consolidation or mass. But it should be, like I said, kind of a combination between that dull and that tympanic sound when you're doing it, as I heard when I did the percussion there.
Okay, and next would be palpate the abdomen lightly first in 6 places. Go ahead.
Okay. So it's always good to use 2 hands when you're doing this. So I'm going to go ahead and push in the right upper. I'm going to push lightly in the right lower. Push lightly in the left upper. Push lightly in the left lower. Then it's always important to palpate in the epigastric area and then the suprapubic area as well. And that's light palpation there.
Next, you will do the same thing, though more deeply, with more pressure.
Okay.
6 places.
So I'm not going to push too much harder just because it can be a little uncomfortable, but you're pretty much going through the same maneuvers here. Right upper, right lower, left upper, left lower, and I'm just gently pushing a little bit deeper, but when you're doing this, it's important to make sure that you give a decent amount of pressure, but making sure that you keep in mind that it can be uncomfortable when you're palpating.
Okay, next is number 57. Check for rebound tenderness. This is after your palpations. You want to check separately with the quick release of the hand in the 4 quadrants and ask the patient if they feel pain with palpation or release of the hand.
Okay, so you're pretty much doing this as you're palpating, both with light and deeper palpation. But this is if you're concerned for like a peritonitic or a acute abdomen. So as you're palpating, sometimes you just want to release quickly, and you may see people, they may grimace with their face, or you may feel a little bit of a tension or some tautness actually in their skin. So you're going to make sure that you do that in all areas. You can just release quickly, and honestly, sometimes if you're pushing in, they may give you some voluntary guarding as well. But as far as rebound, releasing quickly should tell you if there's any sort of sensation that would make you concerned for an acute finding here. And then you make sure you do the epigastric and suprapubic as well.
Okay, next you're going to percuss the liver span. And to do that, you'll percuss along the right mid-clavicular line to identify the transition between resonance, dull, and tympanic, indicating your liver span.
Okay, so as this one's a little tricky because you have to actually find the grooves between some of the ribs, so I'll just pull up a little bit here. Obviously the ribs should be a little bit more dull and you should get a little bit more resonance as you're feeling the liver. But what you want to do is just, honestly you can compare, so I'm on the rib right now, and now I'm going to be on the liver. And you can hear the difference there, hopefully. And what you do is you actually work your way down, just trying to find the grooves where the liver is, until you find the end of the liver. And typically it's going to be just at the inferior edge of the ribs, or sometimes a little bit more superior. It's a little bit tough to feel it in Jordan because he has a normal sized liver. But as I'm working my way down, I can hear some of the resonance. And then when I get to the bottom portion of the ribs here, I kind of lose it. So I'm guessing his liver is obviously a little bit more superior than the bottom of his ribs, which is pretty normal for most people.
Okay. So now you want to palpate the liver edge.
Okay.
This entails placing the left hand on the back between the right rib cage and hip, and then placing the right hand in the right upper quadrant. And then when you do that, asking the patient to take a deep breath, pressing inward and upward under the rib cage when the patient exhales, and then asking the patient to take a second deep breath and holding it as the edge is palpated.
Okay. This one can be a little uncomfortable as well. So you're putting your left hand behind the patient just for some support and for a little bit of actually some pressure when you're pushing down as well. And then always inform the patient what you're going to be doing, because this one can cause some discomfort, especially because you're pretty much digging under the rib cage. So I've got my hand under Jordan's back over here, and what I'm going to do is feel for the inferior edge of his ribs, which I can feel right over here. And then I'm just going to push in a little bit and see if I can feel that inferior portion of the liver. I can't really feel his, but if you can go ahead and take a deep breath in and then release. And right when they're releasing, that's actually your chance to push it a little bit there, because that should, in theory, push the liver down just a touch, enough for you to potentially feel it. I didn't feel his there at the edge. That tells me that he has a pretty normal sized liver. If you really, really dig in there, you can typically feel most people's, but in this case, I wasn't able to feel the bottom of his liver.
Okay, next, this is number 60. You palpate the spleen. So to do that, you put the left hand on the back behind the left rib cage and lift, and then put the right hand in the left upper quadrant, pressing inward and upward while asking the patient to take a deep breath in and out.
Okay. There are a couple textbooks that will ask you to percuss the spleen as well. It's honestly very difficult to do. I've never felt a spleen via percussion before. But palpating a spleen is pretty, in a way it's easy to do, because if someone does have a large spleen, it's pretty easy to feel. And honestly, you can go on either side for the patient here. If the spleen is on the left side, the left upper, so they're telling you to pretty much do what you did for the liver, but reaching across the other side. If for some reason you can't get a good grip, or if you're just more comfortable on the other side, you can rotate to the patient's left and then switch your hands and try to palpate with your left hand to feel the spleen. But since I'm on the right side over here, I'm going to go ahead and try to feel just under the rib cage, and I don't feel anything. So go ahead and take a deep breath in and exhale. And as he's doing that, I'm pushing in a little bit, trying to see if I can feel anything, but I really can't. Spleens, they're typically pretty small. They are tough to palpate unless someone has a large spleen, in which case it's actually pretty easy to feel it. You'll usually feel the inferior edge just below the inferior edge of the ribs over there as well. But in this case, I wasn't able to feel anything, which I expected for Jordan.
And number 61, palpate the aorta in the upper abdomen slightly to the left of the midline.
Okay, so I'm going to go ahead and expose the stomach here again. I'm going to find the midline and then just go a little bit to the left of that and just give a little bit of light palpation here and see if I can feel his aorta. And actually I can feel some pulsations right now too. Sometimes you actually may have to go to the right to feel the aorta. I can feel some light pulsations on this side as well, but actually on the left side you can feel it pulsating a little bit more, which is common. You should be able to feel it in most people when you're pushing down. If someone does have a grossly enlarged aorta, you can obviously feel it with lighter palpation. But in this case, just by pushing down lightly, I can feel it pulsating, which is normal. Okay?
Okay. Final part of this exam, so assess for the kidney tenderness bilaterally. Place your palm on the patient's costovertebral angle, percuss the back of the hand with your fist, and then ask the patient if they feel any pain, and do that bilaterally. Okay,
so you can do this either having the patient lay down, how Jordan is now, or sitting up. You're pretty much pushing on those angles to see if they have any sort of pain or tenderness by their kidneys. So you can go ahead and just reach under here, and I'll go ahead and just push. Do you feel anything on this side?
No.
No? And then I'll go ahead and check on his left side and push. Anything you feel back there?
Nope.
No, okay. Honestly, that's a little bit easier if they're sitting up. What you can do is just use the palm, the ulnar aspect of your palm, and just honestly, you can do a little pound, or you can just kind of like we did with the 99, but you can do it whichever way is more comfortable for you or your patient. All right, so now we're on to the musculoskeletal section.
Okay, so you want to, with the patient supine, you want to uncover the legs and adjust the drapes accordingly, and then verbalize inspection of the hips, assessing for swelling, color changes, and contour.
Okay, so Jordan put on a pair of shorts. In the meantime, we got the drape off, so I'm going to go ahead and pull the gown up a little bit. Just make sure you're informing the patient what you're doing here, just because obviously we're in some private and sensitive areas, so just letting them know what we're going to be doing the whole exam. And I'm just pretty much visualizing the hips at this point, both the left and the right.
So you want to palpate the hips bilaterally and checking the lateral joint compartments as well as the anterior pubic symphysis.
Okay, so I'm going to go ahead and push on both hips here, just comparing left to right and seeing if there's anything that is asymmetric or abnormal. Typically I'd be doing it just from this position because it's a little bit easier just to feel left to right, but for the purposes of this video, I'm just going to go from this stance just so you guys can help, so you guys can see, but nothing that I can feel that's abnormal or asymmetric.
Okay, next is number 65, assess full hip range of flexion bilaterally. And to do this, you grasp the heel or the ankle and move the thigh up towards the trunk as far as possible.
Okay, so I'm going to check out the right-sided flexion first. So I like to grab the ankle. You can either grab from above or below, and then I like to give a little support here by the thigh as well. So I go ahead and usually pick up behind the knee and tell them to relax. I grab the ankle, and I just go ahead and flex up as much as I can. And that's checking hip flexion. Same thing over here. I grab the left ankle, support behind the knee a little bit, and pushing up there. That's our flexion on the left side as well.
Okay, assess full hip range of internal and external rotation bilaterally.
Okay.
To do that, you will position the thigh perpendicular to the exam table and hold the shin parallel to the exam table, and then move the ankle laterally to assess hip internal rotation.
Okay.
And then move the ankle medially to assess hip external rotation.
Okay, so I've got his ankle supported over here with my right hand, and then I usually put my left hand on their thigh, and then whichever way you're going to be rotating is actually the way your hand will rotate. So when we move the ankle laterally, my left hand's going to actually rotate internally, and that's checking internal rotation. And then when my right hand moves medially, my left hand is actually going to come externally rotate, and that's when you're checking external rotation, like that. And then we'll do the same thing on the left side. So you grab the ankle, you want to make sure that you support their thigh a little bit, and then I'm going to go ahead and move laterally, internal rotation, medially, external rotation. And you get a little bit of a clue which way your hand rotates there if you're going internal or external. Okay?
Okay, next, test hip abduction and adduction bilaterally. And to do this with the legs straightened and on the bed, grasp the patient's heel or ankle, move the leg outwards from the body, parallel to the floor, and then return to the starting position, repeating with the opposite leg.
Okay, so this is abduction AB and adduction AD. So abduction, abduction, you're pretty much going away from the body. And then adduction AD, you're going back towards the body. And then same thing over here on the other side. Make sure you support their ankle. Abduction, adduction. Ab, away, AD, towards. And compare side to side.
Okay, next, test strength of the hip abduction and adduction bilaterally. To do this, you ask the patient to push the thighs in against resistance and out against resistance, providing that resistance just above the knees.
Okay, so similar to what we did last time, this time we're trying to compare the strength of both sides. So what you can do is put your hands just outside their knees. I'm going to ask Jordan to push his legs out like we just did. And this is checking his abduction strength. And then you want to have him try to push his legs together like we did for the second portion. So push, good, and that's checking his adduction. So abduction, away, adduction, towards the midline. Okay?
All right, next we're going to verbalize inspection of the knees, assessing for swelling, color changes, and contour.
Okay, so I'm going to look at both knees. They look pretty symmetric to me. So that should be it for that portion.
And then you'll palpate the knees bilaterally, checking the medial and lateral joint compartments as well as the patellofemoral area, i.e. the kneecap.
Okay. So I like to always start palpating along the medial portion of the knees here. You're trying to feel the joint line, and I can feel it nicely on this side, and then I'm going to palpate on the lateral aspect as well. Feeling the joint line once again. Some people with really bad arthritis, they'll have a lot of pain there, so be careful if someone does have bad arthritis. And then you want to push on the kneecap itself, making sure that it's somewhat mobile, not too much, but you want to make sure that it can actually move a little bit. And then you want to check out your tendons. So we got our patellar, and then you always check your quadriceps tendon as well, which is just superior to the patella. So everything feels normal on both sides.
Okay, next you will assess full knee range of flexion and extension bilaterally.
Okay. So what we're going to do here is we're actually going to flex the knee. It's similar to what we did for the hip, but we're focusing more so on the knee here. So what I do is similar. I go ahead and try to grab on their ankle, and then I support their knee a little bit with my other hand. And then what you do is just push in, checking flexion, and pull away, checking extension of the knee. Same thing, support the ankle over here, support behind the knee. I'm going to go ahead and flex Jordan, and then extend him. And that's checking knee flexion and extension.
All right, great. Next part, you will ask the patient to sit up with the knees dangling over the side of the table.
Okay.
And then we will go to number 72.
Okay, so push in the leg rest. I've got Jordan sitting up here, and moving on over here.
So this is number 72. You'll test knee strength bilaterally. So to do this, you'll ask the patient to push against your hand, which will be placed at the distal third of the tibia, while you provide resistance.
Okay, I'm going to swing around to this side while we're doing that.
And then you'll also ask the patient to pull the ankle towards the bed while you provide resistance.
Okay, so go ahead and push me away. This is checking his extension. Push away, checking extension. And then go ahead and pull towards the bed. That's checking his flexion. And same thing over here. Pull towards the bed, and that's checking his flexion as well. Okay?
All right, verbalized inspection of the ankles, midfoot, toes, and plantar surfaces of both legs to assess for swelling, color changes, and contour.
Okay, so I'm looking at the ankles and any portion of the feet, as Jordan said, to assess for color changes or any sort of asymmetry. They both look symmetrical and fine to me.
Then you'll palpate the feet and ankles bilaterally. And at a minimum, you'll want to palpate the medial lateral malleolus and the dorsal surface of each foot.
Okay, so I'm going to go ahead and feel the malleoli on each side and just give a general feel for the foot over here as well. Okay, and then as he mentioned, you want to check out both the plantar and the dorsal surface as well. Plantar, dorsal, plantar, dorsal.
Okay, number 75, we will now test the full range of motion of the ankles bilaterally with dorsiflexion, i.e. with the toes up, plantar flexion with the toes down, inversion with the soles of the foot towards the midline of the body, and then eversion with the soles of the foot away from the midline of the body.
Okay, so for the range of motion portion, we're pretty much just seeing how mobile it is, not really checking the strength here yet, but what we want to do is just give a general feel both up and down. So it's kind of silly, but I always remember plantar flexion as stepping on a plant, and dorsiflexion is just the opposite of that one. So plantar, dorsi, and then same thing, plantar flexion, stepping on a plant, dorsiflexion is the opposite. And then what you want to do is check for inversion and eversion. I always got these confused as well, honestly, but what I remember is inversion is the way that you injure your ankle, like for example on a sports injury. So typically you roll your ankle like that. So that's more inversion, and then eversion is the opposite way, turning the foot that way. To be fair, you could injure your ankle either way, but more typically we tend to injure our ankle this way, which is inversion, eversion, which is that way. Okay.
All right, next test the strength of ankle dorsiflexion and plantar flexion bilaterally by asking the patient to push their foot up and down against resistance.
Okay. So whenever I'm checking plantar flexion, I just ask them to go ahead and step on the gas. Very good. And go ahead and push up. Very good. Step on the gas. Good. And push up. Good. And you can do it whichever way you're more comfortable, whether it's with your hand, the ulnar aspect of your hand, or even making a fist. Depends on how big their feet are and how comfortable you are. Okay?
Okay, number 77, evaluate the lower extremity tone. So to do this, you passively move lower extremity joints, i.e. the hip, knee, and ankle, with the patient draped.
Okay, realistically you're doing that as you're doing the whole exam here. As you're checking flexion, extension of all the joints, you're just seeing how rigid their tone is. Most people will have pretty normal tone as Jordan does. Some people may be a little bit more spastic or a little bit tighter. Some people may be a little bit more flaccid or looser. But as I was going through everything, you pretty much just want to see how easily their joints give while you're doing that. And obviously Jordan's has pretty normal tone everywhere, so nothing to be concerned about there. Okay.
All right. So this is the next portion of the exam, the upper extremity musculoskeletal portion. This is number 78. Assess the full neck rotation by asking the patient to turn their head from left to right without moving the torso.
Okay, sounds good. So actually I'm going to go ahead and rinse my hands real quick because I was just touching Jordan's feet and now I'm going to be touching by his head and neck. It's always a good idea just to make sure that you're keeping your patient's sanity in mind as well. So I'm going to work my way back over to the right side, and then what you're going to do is go ahead and just make sure you can look to the left, look to the right, make sure we have good normal range of motion, and you can also go ahead and look up and look down. Very good, completely normal range of motion.
So that included number 79 as well, full neck flexion and extension, and then we will also do full lateral bending of the neck, asking the patient to incline each ear towards each shoulder.
Okay, so if you go ahead and just pretty much put your left ear on your left shoulder and come back to neutral point, and then right ear to right shoulder and back to neutral. Okay, normal on both sides.
Okay, next you want to ask the patient to lower the gown to the waist and expose the upper arms and shoulders. And we will go to number 81, inspecting the shoulders bilaterally for alignment and symmetry, palpating the shoulder joint between the end of the clavicle and shoulder bone and over the bicep tendons.
Okay, so we'd be looking typically at the bare skin here, but honestly you can get a pretty good sense via a gown or via a shirt anyway. So you're pretty much looking both sides, seeing if there's any asymmetries, and then you're going to go ahead and palpate along the clavicle, and then their humerus and their scapula as well, just to see if there's anything that's, for one, tender or two, asymmetric.
All right, next you want to assess for full shoulder external rotation by instructing the patient to place both hands behind the neck with elbows out to the side.
Okay, so you're going to ask patients to pretty much go behind their neck like this. So I'm going to ask you to go ahead and do that. I can hold your iPad for a second if you want, but you're going to go ahead and reach behind your neck and just see how far your elbows will extend. And that seems like pretty normal external rotation. You can go ahead and switch to the other side as well. And that looks pretty good as well. So that's checking how far they can externally rotate the shoulder.
Okay, and then you want to go for assessing full shoulder internal rotation. To do this, you'll instruct the patient to place the posterior side of both hands behind the back as high up as possible.
Okay, so what you're doing for this is you're asking them to pretty much reach behind them and go up as high as they can with each hand. So I'll ask Jordan actually if you can just rotate a little bit to this side again. We can go ahead and do it on this side. But if you can go ahead and take your right arm and just go ahead and reach up as high as you can. He has very good internal rotation. That can be tough for some people to do, but he has great rotation here. So you can relax that arm and go ahead on to the left side, and he can reach up pretty high. So very good internal rotation on both sides. And then you can go ahead and swing back to the front here.
Okay, next we're going to assess for full shoulder flexion, and to do this beginning with the arms by the sides, asking the patient to raise the arms straight forward and then raising them straight overhead in one motion.
Okay, so if you could go ahead and just keep your arms, you can keep them like this or like this, whichever way you're comfortable. I think more people will tell you to do it with the palms up. So you go ahead and just raise them up and then as high as you can after that. Very good, you can go ahead and bring them back down, and that's great.
All right, and then we want to do full shoulder extension by asking the patient to bring the arms straight behind them, raising them as far up as possible.
Okay, so this one, similar to what we did there, you can go either palms up or down, and you're just going to try to reach behind and see how far you can go. People are obviously a little bit more limited doing this one, but Jordan's got really good extension there as well, so pretty normal on both fronts there.
Okay, next is full shoulder abduction, abduction, asking the patient to raise the arm outwards from the side of the body to above the head.
Okay, so what you're going to do is ask the patients to go arms at the side and just raise them up to both sides. Very good. And you can bring them back down. Perfect.
Next is full shoulder adduction. Following the abduction, you will have them bring the arms down to the side. Well,
Yeah, and you're pretty much doing them, you're usually doing flexion extension at the same time, abduction, adduction at the same time. So as he came back down, that's his adduction, adduction towards the midline.
Okay, next 88. This is test shoulder abduction, abduction strength. Placing the hand on the patient's mid-arm, lateral elbow. You'll ask them to push out against resistance.
Okay.
You can do both arms simultaneously.
Sounds good. So I'll go ahead and I'll stand behind Jordan a little bit so you guys can see. But what you want to do is reach pretty much in the mid-arm and just have you push your arms out to the side while I try to hold you down. Very good. Okay, so he's got good strength there. You can also have people hold up their arms like this and have them push down, but that's probably a little bit easier to do that one.
Okay. Now we will do adduction strength by placing the hands on the inside of the patient's upper arms and then asking them to pull down simultaneously against resistance.
Okay, so what you can do for this one is, I'll do this one at a time, but you can pretty much have your arm in here and tell them to push their arm in towards their midline, and you'll try to resist them. So you go ahead and push your arm in towards your midline. That's very good. And then I'll go ahead and try this side as well. Go ahead and push your arm towards the midline. Very good. That was a little bit easier if you're on the other side of the patient, but just for purposes of this video, I just checked it from that side. All right.
All right, next we're going to verbalize inspection of the elbows for swelling or nodules and palpate them bilaterally.
Okay, so I'm going to look at both elbows, see if there's anything that's abnormal here. Nope, both look fine, feel fine.
And then we go for assessing full elbow range of flexion and extension bilaterally.
Okay, so what you can do is just ask the patient to, similar to what we did with that shoulder flexion extension, you can just have them go ahead and flex and extend. Like you're doing like a bicep curl. That's perfect.
Next, test the biceps and triceps strength bilaterally. You will have the patient bend the arm at the elbow in front of themselves and then brace your non-dominant hand underneath the patient's elbow while your dominant hand is placed on the distal third of the forearm and ask the patient to push and pull against your resistance.
Okay, a lot of verbiage there, but long story short, just go ahead and support their elbow a little bit, and you can go ahead and just rest your other arm on their forearm and just have them like try to flex or make a muscle. So go ahead and pull your arm in close. Very good. And then you do the same thing, excuse me, while I go across here. Help relax their, help support their elbow. Go ahead and pull your arm in a little bit. Perfect. And that's checking both. That's checking the flexion on the elbows and the bicep strength. Okay.
Next is number 93, by the way. Verbalize inspection and palpate the wrist and hands for redness, swelling, and deformity.
Okay. So I'll go ahead and rotate back to this side. I'm always trying to be on the patient's right just for normal convention. So I'm looking at the wrists, looking at both sides, and I'm palpating a little bit and seeing if there's anything that is abnormal, which there is not.
Then you'll assess for full wrist range of flexion and extension bilaterally.
Okay, so that one's a little bit tricky, but pretty much you can have them just rotate, go up and down. You can help them if you want as well. You can do either passive or active, but you're just checking, like I said, up, down, rotation, and everything is fine.
Okay, now testing the strength of the wrist and extension bilaterally. Asking the patient to make a fist or hold out the hands, palms down typically. Place your hand underneath the patient's palm, ask them to move downward against resistance, and then place the palm on the dorsum of the patient's hand and ask them to move up against resistance.
Okay, so this one could be a little bit tricky, but just ask the patient to make a light fist like that. Go ahead and just make 2 fists, and then you go ahead and just push down. Good, and go ahead and pull your wrist up. Very good. And then same thing over here. Push down, very good, and pull your wrist up. Good. That one could be a little tough to do, but that's the gist of it.
Okay, next, assess finger abduction, adduction bilaterally, asking the patient to spread their fingers out and bring them together.
Okay, so if you go ahead and just spread your fingers out and open and close, perfect.
All right, assess finger abduction strength bilaterally by asking them to spread their fingers and instructing the patient to keep you from forcing the fingers together as you push on the 5th finger and the thumb.
Okay, so same thing we did, just have your fingers spread and don't let me close them. You go ahead and push like that. You're pretty much feeling the thumb and the 5th finger and you're pushing. Same thing over here, keep them spread. Don't let me close them. Very good, good strength there.
Okay, assess full finger range of extension and flexion at the MCP joint, asking the patient to spread their fingers straight and then make a fist.
Okay, so you're pretty much just asking them to bend their fingers in, out, and then make a fist, and that's checking the flexion extension at this joint, the MCP joint. Okay, very good.
Test the patient's grip strength bilaterally, asking the patient to squeeze your index finger as you try to pull it out of the patient's grip.
Okay, so I usually give them 2 fingers here, tell them squeeze, and then I try to pull out sometimes, and sometimes you can, sometimes you can't, but you can tell them let me go, and then moving on here.
All right, number 100, evaluate the upper extremity tone. Passively move all the upper extremity joints.
Okay, as we did for the lower extremities, that's what you're pretty much doing as you're doing your whole exam here. You want to see if they do happen to be a little bit tighter or spastic, or if they are a little bit looser, flaccid. Jordan has normal tone, as most people will.
Okay, next you want to ask the patient to stand so that you can inspect the spine.
Okay.
This is number 101. So when the patient is standing, verbalize inspection, palpate the spine. And the patient's gown should be fully open at the back so you can observe.
Okay, so if you're okay standing for a second here, we'll have you stand at the edge of the bed and turn a little bit this way. And I'll go ahead and just shift the gown a little bit here. And I'm going to look at Jordan's spine. And everything looks okay right now. And then the next step there.
So verbalize observation of alignment of the knees, heels, and feet. Observe arches or flattening of feet. Contour of leg muscles for atrophy and inspection. For outward or inward aligning of the knees, and then observe the patient.
Okay, so you're just looking at the knees, at the ankles, at the feet, checking their arches, just in making sure that everything is in alignment, they're not rotated to one side or the other, there's no gross abnormalities, which you're pretty much doing most of your exam anyway.
Number 103, observe full lumbar range of flexion and extension, asking them to bend forward at the waist as far as possible without bending at the knees. And then bending backwards, i.e. extension, observing from behind.
Okay. So this one could be tough for some patients, so you may need to give them a little bit of assistance, but for the most part, you're just going to ask them to keep their knees locked and go ahead and just bend forward as much as you can. Very good. You can ask them to touch their toes. Obviously, most patients can't. Jordan obviously can. He's a flexible guy, so that's really good to see. And then you go ahead and relax, come back to neutral, and then you can go ahead and check extension going backwards, just as far back as you can go. Very good, okay. And that should be it pretty much for the musculoskeletal exam. All right, so we'll have Jordan take a seat here again, and then we're moving on to the neuro exam. We'll go ahead and we'll start with the cranial nerve exam.
Okay, so this is number 105, the cranial nerves. Inspect the external eye structures, evaluating the eyelids, sclera, and conjunctiva. Ask the patient to pull down their lower eyelids and look up while you examine the eyes, and then repeat this for the upper eyelids.
Okay, so we're just going ahead and visualizing the eyes, both above, below, to the sides. You can ask the patient to pull down a little bit, so if you wouldn't mind, if you can just pull down a touch. Some patients may let you do it as well, but it's probably a little bit more comfortable for them to do it. Very good, and go ahead and look up, good. And then go ahead and if you can pull up, and if you could look down. This way you get as much of the sclera view as possible, and you can relax, okay?
Okay. Next, you'll test visual acuity using a pocket visual screening card or chart held about 14 inches away from the patient's face. Ask the patient to cover one eye and read to the smallest line possible, and then repeat with the opposite eye.
Okay, so if you don't happen to have one on you, excuse me while I step across here, these Maxwell quick reference guides, they always have one in the back which comes in handy. I always had this on me, so this usually is what I use. If I don't have this on me, I'll honestly just Google it or get it on my iPad or my phone and just hold it in front of the patient. So typically you're about 12 to 14 inches from them. You want to check one eye at a time. Once again, we're using this portion of it. So hold it about a foot from Jordan's face, and you go ahead and cover your left eye and just read the smallest line possible that you can on here.
E, C, T, P, N, L.
So that's very good. So he's got 20 out of 20 vision. And what you do is you compare the left and the right, and you can have them compare with and without their glasses on as well. Some people will have contacts, so obviously you're just going to do it as is. But if someone does have glasses on, as Jordan does, you can have them do it both ways, or one way or the other, whichever they prefer. And you'll make sure that you check your left and right eye as well. Okay, I'm going to toss that back over there, and we'll go ahead and move on with our exam here.
All right, so this is the visual fields portion, number 107. Test the upper and lower peripheral visual fields bilaterally and separately. So you'll stand 1 foot in front of the patient at eye level. Ask the patient to look straight at you. Put your hands behind the patient's head. Move both hands towards you and ask the patient to identify when the fingers of each hand move into their upper peripheral visual field. Once seen, move the fingers first on one hand, then the other, asking the patient to identify which quadrant has movement, and then repeating the same for the lower fields.
Okay, so a lot of verbiage there. The easiest way I find to do this one, honestly, is you're going to have to stand in front of the patient. So maybe I'll have you just rotate this way so we can at least still see what the camera is. And you're about a foot or two in front of them. It tells you to bring your hands from behind their head, but honestly what I do is usually just bring them in from the side and have the patient just focus on something, usually on your face. I usually tell them stare at my nose or look at my forehead or whatever is easiest. So go ahead and just look at my forehead or my nose, and what I'm going to do is hold up 2 fingers or a couple fingers on each hand, and I want you to tell me how many I'm holding up. So this is what I do. I can bring them a little closer, that was outside my vision too.
1.
Good, and how about down here?
2.
And how about up here?
3.
Good, and then one more time down here.
3.
Good. Okay, so actually I had 4 there, but it was close enough. So,
okay.
But anyway, like I said, there's a couple different ways to do that one. You can bring your hands from outside. You can bring them from a little bit more lateral to medial. You can bring them from the bottom up. It's all depending on your preference. And you can either you can wiggle in one quadrant or the other, or you can just do the multiplication in one quadrant or the other. I tend to see most people do the addition there. Like you hold up a couple of fingers, and you ask them to tell how many of your fingers you're holding up. But if you want to say, which quadrant's moving, that's completely fine as well. So that's completely your preference. For the purposes of your exam, I do it how it's listed in here, but just realize that there's really no right or wrong way to do it. Okay?
All right, number 108, test the extraocular eye movements. This is cranial nerves 3, 4, and 6. Standing 1 foot in front of the patient, you'll ask the patient to follow your finger with their eyes as you make a big H in the air. The vertical components of the H must line up at least as far as the laterals of the patient's shoulder on each side, respectively.
Okay, sounds good. And then if you want to read the next one on there too, because I think that's the convergence one, just so we'll do them at the same time.
Yeah, so we'll check convergence, asking the patient to follow your finger inwards towards the nose and then back out.
Okay, so always make sure that you start at a midpoint or midline, and then make sure the patient's following just with their eyes without moving their head. So that's very important. A lot of people want to move their head, so just try to keep them stationary. And go ahead, Jordan, just follow my finger just with your eyes without moving your head. And you're slowly making an H, always making sure to come back at stopping points. And you're making sure that their eyes are appropriately following, making sure there's no extra movements or nystagmus. And then you come back to the midpoint, and then you come in slowly and back, and that's where you're checking for convergence.
All right, great. Number 110, check direct and indirect pupillary response to light in both eyes. You'll shine the light source into each eye twice, checking first the direct and then indirect pupillary reflex.
Okay, if you want to rotate to the front again, I'll grab the light source off the wall here. You can use, if you have a pen light, you can obviously use that. I don't have one on me right now at this time, but I usually like the wall source if there is one, because it's a little bit brighter and a little bit easier to use. So what we're going to do is you're going to check each eye twice, one time looking at the eye you're checking and the other time looking at the opposite eye. So right now I'm going to go ahead and just look at Jordan's right eye, and I'm going to come in from the lateral portion and look at it. And very good, I'm looking at his right eye that time, and then I'm going to go ahead and check out his left eye. Very good. I'm going to do the same thing again on the right side, but this time I'll be looking at his left eye. Very good. And I'm going to check his left eye, but I'll be looking at his right eye this time. Very good. And you're making sure that he has good responses both times that you're doing that, which he does.
All right, next you will perform the ophthalmoscopic exam in both eyes, turning off the lights and asking the patient to fix the gaze in the distance, standing away from the patient, looking through the ophthalmoscope at the same time as you approach the patient, examining the right eye with your right eye while holding the ophthalmoscope using the right hand, and then examining the patient's left eye with your left eye, and then while holding the ophthalmoscope using your left hand.
Okay, so this one's really tricky to do. To be fair, we don't do it all the time in clinic or in practice, although we probably should. But I've got the ophthalmoscope here. You need to adjust it accordingly just to make sure you're getting a good view. And then just keep in mind a couple good points here. So usually it's a little bit better with the lights off. For the purposes of this exam though, we'll leave the lights on. I'll just go through more of the technique of how to do it. And then it's a little bit easier if you wouldn't mind taking your glasses off real quick too, just so you're not getting that extra lens in there. But you're looking at their right eye with your right eye, and you usually start far back, and you just try to zoom in and see if you can get any sort of sense of their eye. And as soon as you get a good view of it, you start working your way in a little bit closer, and then you start working your way across and rotating. I can actually see a couple of his vessels already. Some people will honestly put their hand on the patient's forehead just so they know when they're getting a little close. And you want to warn the patient that you'll be getting pretty close to get a good look at their eye. It could catch a couple people a little off guard once you start getting a little bit closer to them. And then you go ahead and rotate to the other side, excuse me. So this is Jordan's left eye. So I'll be using pretty much my left hand and my left eye to do this as well. As I mentioned, you can go ahead and put your hand up here if you want for just guiding purposes. In this case, I won't though. So I'm going to look back from here and usually ask the patient to stare at something in the distance, as Jordan's doing right now. So I'm going to look back. I'm going to see if I can see anything in his eye and then start working a little bit closer. And then as you get closer, you can work your way across a little bit, and you can typically see some of the vessels back there. As I mentioned, that's a very tough exam maneuver to do, but it works a little bit better with the lights off, with a little bit of a higher power ophthalmoscope as well.
All right, next we'll test the auditory acuity. This is cranial nerve 8 bilaterally. Asking the patient to close the eyes, whisper into each ear from 1 foot away while occluding the opposite ear. And then you can ask the patient to repeat each word. Okay,
so if you can close your eyes real quick and go ahead and close off your left ear. You just put your finger over there. And I'm going to stand about 1 foot away. I'm going to say, were you able to hear what I said?
Mm-hmm.
What did I say?
Hello.
Okay, and I'm going to switch over to the other side. You can keep your eyes closed, hold your right ear closed, and I'm going to whisper from back here. And what did I say there?
Good afternoon.
Correct. So I said hello and good afternoon. You can obviously use whatever words you'd like, but for the purpose of the exam, we'll just keep it pretty straightforward, keep it pretty PG as well. So moving on here.
Test, so this is number 113. Test sensation in 3 branches of the trigeminal. Ask the patient to close their eyes, ask if they can feel an object such as a finger pad or cotton swab along the forehead, cheeks, and jaw symmetrically and bilaterally. And ask if the feeling is the same on both sides at each level.
Okay, I typically use just my fingers for this because it's a little bit easier. If you want, you could use something like a Q-tip or a cotton swab. But what I'll ask Jordan to do is close your eyes, and what I'm going to do is feel forehead, cheeks, and chin. And I want you to let me know if it feels the same on both sides or not. So right now I'm touching your forehead. Does it feel about the same on both sides?
Yep.
How about your cheeks?
Mm-hmm.
And how about by the chin?
Mm-hmm.
And that's a pretty quick and easy way to do it.
Okay, next is testing cranial nerve 5 motor function. Position the hands on the masseter muscles and asking the patient to bite down.
Okay. So what you do is just ask the patient to pretty much bite down or clench, and you're going to feel this muscle right over here. And as they clench, you can feel it, and then ask them to relax, and you're going to feel that the muscle loosens up a little bit too. So it's right over there along the jawbone over there.
Okay, this is number 115. Ask the patient to close the eyes and keep them closed against resistance. This is testing cranial nerve 7.
Okay, so I'll ask you to close your eyes. Yeah, if you can take the glass off a little bit easier. And I'm going to try to open them. Don't let me open them. Very good. Okay.
Okay, and then ask the patient to wrinkle their forehead. This is also cranial nerve 7.
Okay, wrinkle your forehead. Relax. Okay.
Ask the patient to show their teeth or puff their cheeks out. Also cranial nerve 7.
Okay, big smile. Puff your cheeks out. Perfect.
Okay, ask the patient to say ah and observe the palate elevation with a light source. So this is cranial nerves 9 and 10.
Okay, so I'll just have you open your mouth and say ah. Very good. He's got a good elevation there. You can obviously look with the light source if you need to, but typically you can see good elevation without it.
Ask the patient to stick out the tongue and move it side to side. This is cranial nerve 12.
Okay, so stick your tongue out and go left and right. Perfect.
Okay, ask the patient to rotate or turn the head against resistance, placing the fingers against the patient's chin. This is cranial nerve 11.
Okay, what I usually do is just put usually the back of my hand just against their chin and just ask them to look towards me. Very good. And then same thing, I do it on the other side, say look towards the wall. Very good. This way you're not giving them too much resistance on their face, which can be a little sensitive.
Okay, number 121, ask the patient to shrug the shoulders without and then with resistance on both sides.
Okay, so first, just without resistance, you can just go ahead and shrug up and relax. And now I'm going to push your shoulders down, and go ahead and push against me. Very good.
All right, next is reflexes. So there's 122. Test the brachioradialis reflex bilaterally. Ask the patient to rest the hand on the lap with the palm turned down, with the palm turned toward the midline. Place the finger on the brachioradialis tendon and strike your own finger with the hammer.
Okay, so I'm going to grab my reflex hammers from this side over here. I've actually got two here. I think this is probably the more common one, the more typical one that you guys see. Honestly, this one's a little bit lighter though, so I personally don't like using this one. I've got this one which looks a little bit funkier, but it's actually heavier, and which I think works better for reflexes. So this is the one that I like to use. The brachioradialis is a little bit of a tough one to find. Typically it's about halfway along the forearm, usually a little bit more on the lateral side here. And for all these reflexes, what you're doing is just trying to find where the tendon may be, and you go ahead and push, and then you go ahead and just hit your finger and you see if you feel the tendon fire beneath you. He's got actually a really good reflex there. So you can feel it underneath his finger, and you can also see his hand just kind of jump along over there as well. So good reflex on that side. And you're going to check on both sides, but just for this purpose, I'll just go ahead and check on your right side.
All right, next, test the biceps reflex bilaterally, asking the patient to bend the elbow and rest the arm in their lap, placing your finger on the biceps tendon and striking your own finger with a hammer.
Okay, so honestly, as he's sitting right now, it's a really good way to check it. So I'm going to go ahead and just feel for his tendon, which is right over here, and you go ahead and just give it a hit on your finger, and he's got a good reflex there, and you make sure that you check it on both sides.
Next, triceps reflex bilaterally, asking the patient to bend the elbow with the palm towards the body as you support the arm. Use the reflex hammer to strike the triceps tendon.
Okay, this one could be a little tricky to elicit as well. What I usually will do is ask the patient just to pretty much let me take their arm and just go ahead and just try to relax it as best you can. A lot of people want to help you there. I just tell them don't help me, just let me take your arm, and you're going to try to feel their tendon, usually back here. And as soon as you get a good sense for it, what you can try to do is move your thumb over by that spot, and then you can strike your thumb if you find the tendon. This one's a little bit tricky to elicit sometimes, especially because a lot of people, based on positioning or based on how much they're actually going to let you give their arm, it's tough to elicit, but it's a little tricky to get Jordan's there, but make sure you do that on both sides as well.
Okay, test the patellar reflex bilaterally, moving to one side of the body to avoid getting kicked. And then locate and strike the patellar tendon.
Okay, this one's usually pretty easy to elicit. You just kind of go ahead and feel for that patellar tendon as we did earlier. And you can either do this one straight on the tendon or on your finger. I prefer to go on my finger because then you can feel the tendon fire beneath you. He's got a good one there. You're not going to get the leg kick or the leg jump that you're accustomed to seeing like on TVs and movies. But usually, if you can at least feel the tendon fire below your finger, that counts for a good reflex. Okay?
Okay, and then you want to test the Achilles reflex bilaterally by lifting the ball of the foot, slightly dorsiflexing it, and striking the Achilles tendon.
So this one's important. You want to make sure that you dorsiflex their foot just a little bit, because that's going to actually align the tendon a little bit better. If their foot's just kind of hanging flaccid there, the tendon actually won't really be taut, and it's tough to get a good reflex. So you just go ahead and you push up their foot a little bit, you feel for the tendon with your finger. Sometimes you can even prop it up with your leg if you want a little bit, and then I try to hit my finger from this side, and you see he's got a really good result there. And then same thing on this side. So I'm going to feel for the tendon, I'm going to dorsiflex him a little bit, prop it up with my knee, and he's got a good reflex on that side as well. I'll come back to the right side over here.
Okay, next is number 127. Test the plantar reflex, i.e. the Babinski sign, bilaterally. Scrape an object across the sole of the foot, beginning from the heel, moving towards the small toe and arching medially towards the big toe. Okay,
so this one is a little bit tricky to do as well, but what I'm going to do, Jordan, just prop your leg up real quick just to show how we would do it, and I'll go ahead and just prop it on my leg right here. But what you really want to do is you're starting from the heel and you're working your way up. You can go either side, but typically I think they tell you to go towards the big toe. You're supposed to use the bottom of your reflex hammer or something kind of sharp, but it can actually be pretty painful, so just be cautious what you're doing. You can even use your knuckle too, which I tend to use. So you just drag your way up a little bit, and you should get their toes to curl in a little bit. If the big toe happens to flare out and not flex like that, that's abnormal. So that's what you'd be doing on both sides. Typically, patients are lying in the bed in the hospital, so it's a little bit easier to do, but you can do it with them sitting at the edge of the bed as well.
Okay, next, demonstrate the difference between sharp and dull in the upper extremities, with a sharp, like an broken end of a cotton swab, and a dull, the cotton tip object. With the patient's eyes closed, alternate between the sharp and dull tests on the bilateral upper extremities, both proximal and distal, asking the patient to report each sensation.
Okay, sounds good. So I can see if we have any of the Q-tips in here. Sometimes we do, sometimes we don't. Actually we do, so that worked out pretty well. Alright, so what we've got here are pretty run-of-the-mill cotton swabs or Q-tips, or you can find them in most of the physician offices or in the hospital as well. So these are good. You can get you can just take one of these and break it in half, and then you can use the tip as your soft portion or your dull, and then you can use either side as the sharp portion. Make sure it's not too jagged though, because they can be a little pointy. But as a good general rule, it's pretty easy to just break one of these and use it. So what you'll do is you'll just pretty much ask the patient to, as Jordan is, just relax and then close your eyes for a second. And what I'm going to do is I'm going to touch on different areas and see if he can tell me if it's, for one, if he can feel it, and then two, if it's sharp or dull. So I'm going to go ahead and start on the right side. Can you feel that?
Sharp.
Okay, that was actually the dull one, but it's all right. But over here, yeah, it was.
Okay, wow.
All right, let's try it again.
That was sharp.
That was sharp, you got it. And then ideally we'd go on the skin, but I'll just go ahead and pull this up a little bit. And how about over here?
Dull.
That was the dull one. Okay, and then we can go ahead and do it on the other side. And you're just pretty much comparing, proximal to distal, distal to proximal, sorry, and then left versus right. So can you feel this?
Dull.
That was dull, correct. And then over here,
Sharp.
good. And then over here,
Sharp.
good. Okay. So that's comparing, as I said, working your way distal to proximal, left versus right.
Okay, next, test the vibration sense in the upper extremities bilaterally, asking the patient to close their eyes, placing the vibrating tuning fork on each thumb, on bone specifically, and then once the patient's acknowledged the vibration sensation, manually stop the vibration and have the patient indicate when it is stopped.
Okay, so I'm going to grab my tuning fork from over here, excuse me. And what you do is just pretty much have Jordan exactly how he is right now. And what I do is put it right on the portion of the knuckle by the bone. I'll ask you to close your eyes. You activate your fork, and then you put it on there. Can you feel that vibrating?
Mm-hmm.
Let me know when it stops. And then you go ahead and just manually stop it.
Stop.
Okay? And then you'll do the same thing on the other side. Can you feel that vibration?
Mm-hmm.
Okay, let me know when it stops.
Stop.
Okay, good.
Okay, next you will test position sense in the upper extremities. With the patient's eyes open, demonstrate manipulation of the patient's pointer finger, placing the finger on each side of the pointer, placing the thumb and finger on each side of the pointer finger while stabilizing the joint with the hand, up and down, and then asking the patient to close their eyes at the test, and then telling them if it is up and down.
Perfect. So what you want to do is show them what you're going to be doing beforehand. So what you do is grab their finger, and then as he said, you go on the lateral sides of it, because if you were to go up and down, it can be a little skewed. You go on the lateral side, and you tell them, you show them, this is up and this is down.
Mm-hmm.
Then you ask them to close your eyes, so go ahead and close your eyes. Which way am I going?
Down.
And then how about now?
Up.
Good. And you go ahead and you make sure you do that on both sides.
Mm-hmm. Okay, next, demonstrate the difference between sharp and dull lower extremities, in the lower extremities, and some proximal asymptomatic area with a sharp and, i.e., like we did before, broken end of the cotton swab versus a dull object with the patient's eyes closed.
Okay. And then one thing you could do, which I didn't do for the upper extremities, is you can let them know which is sharp and which is dull. That's probably what threw you off in the first place, but you can even have them feel it too. Like this is the dull one, this is the sharp one.
Mm-hmm.
So you do it similar to how you did the upper extremities. Ask the patient to close their eyes,
Mm-hmm.
and then what you do is you can check. You can work your way proximal to distal here. So I'm going to go ahead and say, can you feel me poking you on the right?
Yes.
Is that sharp or dull?
It's dull.
Okay. And then how about over here on the left, in the middle?
Mm-hmm.
Is that
sharp?
okay? And then how about over here on the right?
Yes, dull.
Gotcha. Okay, so you work your way down or work your way up, whichever is easier, and you want to check both sides, alternating between sharp and or dull.
Next, vibration sense, now on the lower extremities bilaterally, asking the patient to close their eyes, putting a tuning fork on the great toe, again on the bone, and then again acknowledging the vibration sensation and when it's stopped as well.
Okay, so similar to what we did for the thumb, what you want to do is just find the joint or the knuckle by the big toe, activate your fork, have them close their eyes, let me know if you can feel the vibration.
I can.
Okay, and let me know when it stops.
Stop.
Good, and then do the same thing on the other side, activate your fork, put it on the joint, let me know when you feel it,
I feel it.
and let me know when it stops.
Stop.
Very good. Okay.
Okay, now position sense in the lower extremities, just as we did in the upper extremities.
Okay. So same thing, you can have them look to first start it, but you grab on the sides of the toe and say this is up and this is down. If you don't want them to close their eyes, you can just block it from them and you can just say, okay, which way am I going?
Down.
Good?
Down.
Good, and then you compare that left to right as well.
So now it's coordination, testing finger to nose coordination bilaterally, asking the patient to touch their index finger to your finger, then to their nose, moving the finger, your finger in several directions. The patient's arm should extend fully each time.
Okay, so what I usually do is stand a couple feet away with my pointer finger, ask them to touch my finger, touch your nose, and now back to my finger as I'm moving a little bit the whole time. Back to your nose, back to my finger, back to your nose, back to my finger. Okay? And make sure you're not moving your finger as they're reaching for it. You should find about 3 or 4 stationary points as you're working your way across. Always making sure they reset on the nose and then touch the finger.
Okay, and now testing coordination with rapid alternating movements, having the patient alternate slapping the front and back of their hands against their thighs, and you can have the patient mimic you. And do this as quickly as possible.
Yeah, this one could be a little tough to explain, so I always just tell the patient, just pretty much do what I do. You have them go on their knee or on their thigh, and you just go back and forth as quick as you can. And you just say, do that as long as you can for as fast as you can. And they should be able to do it pretty quickly like Jordan's doing. Okay, you go and relax and you have them do it on both sides as well.
All right, test for lower extremity coordination bilaterally, asking the patient to take the heel of their right foot and place on the heel or on their left knee. And then dragging down and up the left shin and repeating on the opposite leg.
Okay, so if you can take your right heel and put it on your left knee and just pretty much go down and then work your way back up, perfect. And you can relax and take your left heel, put it on your right knee, and work your way down your shin and back up. Sometimes you may need to demonstrate that for people. It could be a little tough for them to comprehend what you're saying, but you can just try your best to orient them and direct them to doing that. You just tell them to take the heel, put it on the opposite knee, and go up and down the shin.
Okay, next is gait. This is number 137. Observe the patient's normal gait, asking the patient to walk away from you, pivot, and return to you.
Okay, sounds good. So I think these are the last few steps here. I can take your iPad for a second while we do these last few. What we can do is probably step back in this area and just have you
This way?
just walk forward,
Okay.
just with a normal gait, and then pivot and return back. Very good. And now if you can walk on your tiptoes going that way, this is number 138. And you can relax and you can do 139 and walk on your heels, and you can walk back, please. And then next for number 140, you want to have them do the tandem gait, where they're going 1 foot in front of the other, kind of like you're walking the line. And make sure that for some patients are unsteady, you're keeping a hand for some guidance for them. But obviously Jordan is pretty steady, so no concerns for that. So the last few here, test for dorsal column signs with the Romberg test. Instruct the patient to put feet together while standing, arms down at the sides, and then close their eyes. Observe the patient for falling for 5 to 7 seconds. Stand in front of the patient with your arms close by in case the patient falls. So, as we mentioned, you go ahead and stand exactly how you are, hands to the side. I want you to go ahead and close your eyes and just try to keep your balance the best you can. And honestly, I like to stand by the sides and just keep one hand forward, one hand back, just in case they do wobble either way. Okay, you can go ahead and relax. Now we're on to 142, test for drift of outstretched arms. Instruct the patient to spread feet shoulder width apart, so you can go ahead and widen your feet just a little bit. Ask the patient to close their eyes and hold both arms straight out in front of them with their palms up. Observe for 10 seconds for signs of one arm dropping below the other or pronating. So, perfect, your shoulder width apart. If you can go ahead and hold your arms completely in front of you like that with the palms up, and go ahead and close your seconds. Close your eyes for 10 seconds. I like to go ahead and keep my hand behind them because some people could get a little unsteady doing this as well. And what you're doing is seeing if, for one, the arms drift side to side or drift up and down, or two, if they happen to be rotating their palms a little bit like that or supinating. In this case, he's doing completely fine in his supination. He's not pronating at all. And you can go ahead and open your eyes and relax. And then lastly, inform the patient that you have concluded your physical exam. Thank them for their cooperation. And that's it. So guys, that's the whole head to toe exam. I know it's pretty thorough and there's a lot to go through it, but hopefully that was pretty helpful for you guys. If you guys have any questions about anything, please feel free to email me. Like I said, my name is Frank Tenuto, Tenuto. I'm one of the hospitalists here. And Jordan, if you want to just give them your name as well, one more time.
Jordan Sharping, one of the residents, internal medicine.
So hopefully that was helpful for you guys. Best of luck with everything, and just let us know if you have any questions. All right, thank you.